do. I assume that the clock counting down means that this session has started. Thank you all for staying so late. Final session on a very full day, but you've made it almost to the end and we've saved the best for last. I will hand over to my co-chair to introduce himself and then I will introduce myself.
You can begin.
Okay, I will begin. My name's Rupa Kanapathy-Pillay. I'm an infectious diseases physician. I work as an infectious diseases advisor for OCP, and I focus on antimicrobial resistance, antimicrobial stewardship in particular.
Thank you very much. Je vais parler en français.
So, thank you. We'll be speaking in French. So, as my name is Didier Guillemot. I'm professor in internal medicine, and I'm in charge of the department, and also at INSEM we work on antibiotic resistance, and we were asked Rupa and myself, to provide you with an overview, so to speak, of bacterial resistance. So I first would like to remind you of the fact that antimicrobial resistance, AMR, doesn't only involve bacteria, it's also about other pathogen agents. We saw this early on, and it also has to do with viruses and also some vaccines, indeed. When it comes to understanding all these, actually, the situations are not that different one from another. In very recent works that were published in the Lancet review in 2024, the estimates of the consequences of AMR is estimated to be approximately 4 million deaths globally every year. As for the death linked with AMR, and 1 million for death attributable to resistance. As you might imagine, data was mainly from developed countries, and if you read the paper and all the reviews, you soon realize that there is a lack of visibility, especially in Africa, but not only, also in other low-income countries. And in my view, this is a very important issue because those resisting genes
avec des taux, même en communautaire, on peut
even in the community,
des prévalences de portage, de colonisation,
have a colonization rates of approximately 40% regarding enterobacteria, for example.
Alors, je comment on dit en anglais, stresser.
And I'd like to stress two or three things. First,
quand on prescrit un
where you prescribe an antibiotic, you should always have in mind that the patient to whom this is being prescribed is colonized by a resistant bacteria, and that the antibiotic could have a selective impact on that resistant bacteria and could increase the risk of transmitting this resistant bacteria to another person. And the major issue here is that the clinician doesn't see this. The clinician doesn't see the risk of an increased transmission. So an increased transmission risk. And obviously this is a major issue when you think in terms of antibiotic stewardship. Also, there are some populations that are more vulnerable than others. AMR in nosocomial infections isn't something that you only see in large hospitals and in high-income countries. This can also happen in small hospitals,
notamment
and also with the resistant enterobacteria.
C'est les questions d'augmenter la vulnérabilité de certaines populations, notamment dans les pays
understand that populations are more vulnerable in low-income countries, and you have to think about those people, for example, young women with the gonococ resistance, because this could increase the infertility rate, and also have in mind children.
Nouveau-nés,
newborns, or at least
nouveau-nés qui
very young
ont
children under 1 month of age. So I'll stop there. But really, this highlights how important it is first to monitor things, and second, to be aware of all this and to use the right approaches in order to improve the diagnosis and to choose the most suitable antibiotic, bearing in mind that, the less the better. And I will give the floor back to Rupa.
So I'll switch to English. Apologies to the French speakers. So the 3 presentations that you're about to see emphasize the widespread importance of antimicrobial stewardship and highlight that opportunities for its implementation are really present at every level of healthcare. We are aware that the use of ceftriaxone is linked to a higher risk of multi-drug resistance. Yet we use it in almost every guideline for treatment of bacterial infections in low and middle income contexts. This evening session, will focus on ways to enhance current prescribing practices for commonly used antibiotics, as well as address the anticipated need for newer antibiotics to combat multi-drug resistant bacteria. So on that note, I will introduce our first speaker. Dr. Gerald Hangaika is a medical doctor working for MSF as an operational research MD in Harare, Zimbabwe. He holds a medical degree from the University of Zimbabwe, a Master of Science in Health Economics from Mbare University, and a Master's in Public Health from the University of Manchester. And he will be presenting on integrating rapid and laboratory sexually transmitted infection diagnostic tests into symptomatic management in an adolescent clinic in Harare, Zimbabwe.
Thank you. So good afternoon, everyone. My name is Dr. Gerald Hangaika, and I'm honored to present on behalf of our team. So today, I will be presenting our study, integrating diagnostic tests for sexually transmitted infections into symptomatic management at an adolescent clinic in Mbare, Harare, Zimbabwe. So sexually transmitted infections, especially bacterial and viral ones, remain a major public health issue. The most common ones include gonorrhea, chlamydia, trichomonas, and syphilis. They can increase HIV acquisition risk and lead to severe maternal and neonatal complications, and also cause long-term consequences such as infertility. Over 1 million new STI are acquired globally every day, with adolescents and young adults amongst the most vulnerable. Effective antibiotic treatment is available for most STIs. However, many STIs are asymptomatic and or may have non-specific symptoms, so effective diagnosis is key to effective treatment. Available diagnostic options include molecular tests, which are widely available in high-income countries, also rapid tests, and the syndromic management, which uses symptoms and clinical algorithms. Mostly low and medium-income countries like Zimbabwe mostly rely on this syndromic management. This allows rapid same-day treatment, but has important limitations like missing asymptomatic infected individuals and giving unnecessary treatment to some symptomatic patients. So the study aimed at evaluating the added value of integrating diagnostic tests. Specifically, we measured the proportion of missed treatment and over-treatment using the syndromic approach compared to diagnostic-based approach. For this study, we introduced additional diagnostic tests for chlamydia trachomatis, for Neisseria gonorrhea, and Trichomonas vaginalis, using a gene express-based, which is lab-based, as well as the awesome rapid test, which was performed at the consultation rooms. The study was conducted in Mbare, one of the most densely populated areas in Harare, with residents of low socioeconomic status. The MSF Mbare project runs an adolescent clinic within the Mbare Polyclinic, which provides free youth-friendly services focused on sexual and reproductive health, including and based on the syndromic management of STIs and rapid testing only for HIV and syphilis. This was a cross-sectional study with follow-up for results. We included adolescents aged 16 to 19 years old attending the clinic for any reason and had been sexually active in the preceding 12 months. At initial consultation, clinical examination and treatment was provided based on syndromic approach, and all tests were done. For females, vaginal discharge syndrome or low abdominal pain was managed as possible infection with chlamydia, gonorrhea, and or trichomonas. For males, urethral discharge was treated as possible chlamydia and gonorrhea. We defined overtreatment when participants with a syndrome tested negative, and missed treatment when participants without the syndrome tested positive. We enrolled 402 adolescents, of which 200 were females and 202 were males. Most of these were either 18 or 19 years old, and a third of the female participants were pregnant. And 7% of the participants were HIV positive. 43% of the males and 29% of the females had 2 or more sexual partners in the preceding 2 months to enrollment, and no method of STI prevention was used by almost half of the female participants. I will now present the comparison between the syndromic and test-based diagnosis. First, I'll present the results for chlamydia. Let's start with the females. So in the study, 110 were diagnosed using the syndromic approach, and these are the participants represented in red, this one. And when we look at the test results, 65%, those ones in blue, were positive for chlamydia. And only 33 out of the 110 with the syndrome tested positive for chlamydia trachomatis, which is this 33, which represents 70% overtreatment. On the other hand, only 32 out of the 65 tested positive and had not reported symptoms, therefore were missed by the syndromic approach. That's almost half of the participants, 49%. For the males, similarly, those with urethral discharge syndrome, 32 males, which was around 74% of the participants, were overtreated in red there, and 4 positive males, which is 27%, missed treatment. For gonorrhea, similarly from the 200 female participants, 110 females were diagnosed with the syndrome of vaginal discharge and are represented also in the red circle. Those with positive test results in the blue were 44, and only 34 out of the 110 with syndrome tested positive for Neisseria gonorrhea. This is that 34, which represents around 69% of the females which were overtreated. On the other hand, only 10 females out of the 44 who tested positive did not report symptoms and were missed by the syndromic approach. That's around 23% of the females. For the male counterparts, those with unilateral discharge, 15 males here in red, which is around 35%, were overtreated, and only one male patient was positive and had missed treatment, which was around just 4%. For Trichomonas vaginalis in females, in red there, 74 represented those that were overtreated, and in blue there, the 9 represents those that missed treatment. So about 74% were overtreated, and only 26% missed treatment at initial consultation. In terms of follow-up was needed for those that missed initial visit. For chlamydia, 34 participants were missed, and of these, 25 were successfully contacted per phone, and 15 came back for consultation, with only 14% receiving the required treatment. Similarly, for Neisseria gonorrhea, there was 12 that missed treatment, and 18 that were contacted by phone. We had 6 that came for consultation, and 6 that received treatment. Overall, we had 46% that needed treatment that received the actual treatment after the follow-up. So in conclusion, high STI prevalences were noted with chlamydia trachomatis at 20%, Neisseria gonorrhea at 18%, and Trichomonas vaginalis at 9%. Comparing syndromic versus diagnostic test approach, on average, there was a 70% overtreatment for females and a 55% overtreatment for the males. And in terms of missed treatment, 20% of the females were missed and only 2% of the males were missed. Feasibility constraints were noted related to the time to getting the results, as well as the cost for procuring the GeneXpert cartridges. We therefore recommend, following the study, expanding access to diagnostic testing, particularly for females, and ensuring that the test results reach participants within a short time. So thank you all to the, I would want to extend a thank you to the adolescents who participated in the study, our colleagues at the National Microbiology Reference Lab, our colleagues in the MSF, some, the MOH Zimbabwe, and the Epicentre. Your collaboration made this work possible. Then a special mention goes to the late Grace Ayuelu, the former PMR for the Mbare project, and the late Andrew Tarupiwa, the study PI, both passed on in 2024 towards the end of enrollment for the study. Thank you for your attention.
Écoutez, merci beaucoup.
Okay, well, thank you very much.
La prochaine présentation
So the next presentation
va vous être proposée par
will be made
Emily
by
Lynch,
Lynch,
qui est épidémiologiste,
who is an
qui a beaucoup travaillé,
epidemiologist,
donc qui travaille à Epicentre déjà depuis plus de 10 ans. Elle a beaucoup travaillé sur de nombreux pathogènes, choléra, Ebola, paludisme, rougeole, méningite, hépatite C, et résistance aux antibiotiques, et aussi sur des questions de neurodéveloppement. Donc voilà, et là, elle veut présenter quelque chose qui s'intègre vraiment dans le cadre de Antibiotic Stewardship. Merci beaucoup.
Good evening, everyone. Today, I will be presenting a retrospective chart review that we conducted at Barnersville Junction Hospital in Monrovia, Liberia. The global burden of antimicrobial resistance is substantial, accounting for more than 3 million child deaths in 2022, 22% of which were in Africa. Sepsis, which is a systemic reaction to a bloodstream infection, is a leading pediatric diagnosis in MSF-supported facilities. Antimicrobial resistance makes the timely and effective treatment of sepsis much more difficult, and it leads to poorer prognoses. In 2019, an estimated 20 million children under the age of 5 died due to sepsis. So what tools do we have to respond to antimicrobial resistance? One tool in the package of antimicrobial stewardship is the Cumulative Hospital Antibiogram. This is a summary of resistance patterns from clinical samples from the same patients in the same hospital during the same period of time. The Cumulative Hospital Antibiogram is a critical tool in the surveillance of antimicrobial resistance. It tells us what pathogens are present in the population, which antibiotics are they resistant to, and what are the patterns of resistance over time, including to what degree are multi-drug resistant organisms present. However, there are some important limitations to the usefulness of the Cumulative Antibiogram. It serves as an alert system, but it's a very general overview, and to effectively guide the adaptation of empiric guidelines, additional clinical data is needed. So we designed our study to answer some of these questions. We had several questions for the study. One, are clinicians appropriately treating sepsis empirically and in targeted treatment? Two, where are patients acquiring resistant infections? And three, do clinicians need to be treating community and nosocomial acquired infections differently? At the population level, we wanted to see how the results of the study plus the cumulative antibiogram could be used to effectively adapt empiric guidelines. Before we go further, I want to review a few definitions for key terms. The cumulative antibiogram, which we've discussed already, is a summary of the susceptibility of bacteria to different antibiotics in clinical samples in the same population in the same period. So the antibiogram, otherwise known as the final result, so there's two stages of microbiology results after a sample is collected. The first stage is the preliminary result, also called the gram stain, and that's an initial classification of a pathogen from a clinical sample. It can take 1 to 2 days. The antibiogram, the final result, is the final antimicrobial susceptibility testing for that patient, and that can take 3 to 5 days or even longer to provide from the lab. Empiric treatment is treatment based on clinical signs and symptoms, and then according to guidelines. It's very broad, it relies on trial and error, and it can lead to delays, particularly when the bacteria or the resistance profile is not addressed adequately by the empiric treatment. Targeted treatment, on the other hand, is after you have microbiology data where you can effectively treat the causative pathogen of that infection. Nosocomial is what we call infections that are assumed to have been acquired at a healthcare facility. For the purposes of our study, we defined this as infections acquired after post 48 hours from admission. Community acquired are infections acquired in the community. And for the purposes of this study, we define that as any positive blood culture in the first 48 hours after admission. So our study was conducted at Barnersville Junction Hospital in Monrovia, Liberia. This was an MSF and MOH supported hospital that was operating from April 2015 until September 2022. The microbiology lab supported by MSF opened in 2019. Our study enrolled patients from July 2019 to September 2022 retrospectively, and these patients were aged between 1 month and 15 years. We began with 465 positive and eligible blood samples. That represented 444 patients. Of these, about 85% were considered eligible for the chart review. That's 377, and the remainder were excluded due to missing or incomplete chart data. So we undertook a retrospective chart review in this study. We assessed the appropriateness of empiric treatment, the appropriateness of targeted antibiotic treatment, and the presumed origin of infection based on the definitions that I reviewed already. For appropriateness, we define this for the purposes of the study as being in accordance with guidelines or being reasonable based on clinical review of expert opinion. And we had a second parameter, appropriateness, which was to assess the drug choice. If the drug choice was appropriate, then we further assessed the dose, the duration, and the route. So overall, our patients were very young and very ill. Most of the patients were under 3 years of age. The majority, 3/4, were in the ICU at some point during their admission, and almost half were severely malnourished. This cohort also faced a very high mortality rate. More than 36% of the patients passed away during their admission. Where a reason for culture was indicated, it was primarily sepsis or suspected sepsis. The culture was usually taken in the emergency room and followed by the ICU. So coming to origin of infection, we do find that more than half appear to have been acquired in the community. However, we see a very high proportion of nosocomial infections as well, which accounted for 1/3 of all the infections in the cohort. Looking at the causative pathogens, we find that community-acquired infections are the majority in all categories, except in non-fermenting bacteria, which along with gram-negative Enterobacterales accounts for the majority of nosocomial infections. The most commonly identified pathogens in this period were Klebsiella species, particularly Klebsiella pneumoniae at 23%, Escherichia coli at 11%, and Staph aureus at 9%. Acinetobacter baumannii and Pseudomonas species were also identified, each of them in 31 samples, including in community-acquired infections. We found a concerning rate of multi-drug resistant organisms in this cohort at 20% of samples. Approximately 70% of these were resistant to cephalosporins, 20% to carbapenems, and 10% to cloxacillin. Considering the appropriateness of antibiotic treatment, we reviewed nearly 1,300 antibiotic prescriptions, and please note here that the totals may represent more than one antibiotic per patient. Overall, almost 80% of empiric prescriptions were deemed appropriate. This was primarily determined by their accordance with MSF guidelines. Where the drug was appropriate, we further evaluated dose and duration. In empiric prescribing, the dose was more often too low rather than too high, and the duration was most often too short rather than too long. In contrast, we see a drop in appropriateness in targeted treatment to 66%. A larger proportion of those prescriptions were in some way not compliant with MSF guidelines, however, were determined to have still been appropriate by clinical review and agreement. Duration was most often considered to be too short and when it was inappropriate, and the dose was more often considered to be too high, similarly to empiric treatment. So let's return to our study questions. Clinicians, by and large, are empirically treating appropriately. During the targeted treatment, we see that there was a reduction in appropriateness, and we see improvement needed in this area. Patients are, by and large, acquiring resistant infections in the community. However, we did see that 1/3 acquired nosocomial infections in this cohort. Do clinicians need to treat community and nosocomial infections differently? We can say probably yes, due to the high rate of multi-drug resistant organisms, as well as the identification of unexpected pathogens in the community. At the population level, our findings do support changing the first-line treatment and also to investigate additional risk factors for multi-drug resistant organisms. So some questions remain. How do we continue to improve our antimicrobial stewardship and reduce the burden of sepsis with the tools that we have? It's one thing to develop new guidelines, however, it's another thing to figure out how to successfully implement those. We need to ask what are the challenges and the enablers of implementation for clinicians in our projects, and what kind of follow-up is needed to ensure implementation is successful. And then at the population level, coming back to the guidelines, when and how do we adapt empiric guidelines? Notable questions, especially regarding the threshold for adaptation, remain, and also whether there are risk factors that we can identify at the individual level for multi-drug resistance. And finally, how can the cumulative antibiogram be leveraged to become more useful regionally and nationally? I would like to thank the patients whose data contributed to this study, the staff from MSF and the study team, and the Liberian Ministry of Health and Social Welfare, who were very instrumental in helping us complete this study. Thank you so much.
Thanks very much, Emily. I'll introduce our next speaker. Céline Langendorf is a pharmacist and medical scientist and joined Epicentre Paris in 2011. She's currently involved in various clinical or vaccine trials and antibiotic resistance studies. She also coordinates Epicentre's research laboratories in Niger and Uganda. Take it away, Céline.
Bonjour à tous. Je vais vous parler
Hello everyone.
du diagnostic. I'm going to tell you about bacteria, diagnosing highly resistant bacteria, and what about a rapid test that could help us to confirm them and characterize those bacteria. But what does it mean concretely? Let's take the example of treating a sepsis provoked by very common bacteria, which are gram-negative. According to the MSF guidelines, first you should use empirically, before getting the DST, penicillins or cephalosporins, such as ceftriaxone. Should you see in the results that it's resistant to the antibiotics, because you can see that they produce BLSE, well, the second-line antibiotic could be a carbapenem. However, if your bacteria is also resistant to carbapenem because it does produce an enzyme which is called carbapenemase and therefore is a CPE bacteria, well, then you have to fall down on colistin or on other antibiotics, like cyclines. And so we are going to focus on these CPEs. There are very recently on the list of very resistant bacteria, and depending on the region, it can be as high as 50%. Mortality can be as high as 50%, and you can find them in hospitals and provoke difficult to treat epidemics. Now, CPE is difficult to treat in MSF settings. The current antibiotics are not really very efficient and also very toxic for kidneys. There are alternative antibiotics, but not available in MSF settings, and we would like to have them in our guidelines for targeted treatment of infection. They are more efficient and safer, but more expensive, and some of them are difficult to get. However, what matters for the time being is that their efficiency depends very much on the type of carbapenemase these bacteria produce. What's the role of a lab in diagnosing these infections? Well, the lab can identify carbapenem resistance and then should be able to confirm that this resistance is due to the production of carbapenemase and then target those enzymes that are produced. There are several classes of these enzymes, A, D, B, and you have here the list of the 5 that are most frequently found in the world. These methods for typing, phenotyping are not available, or molecular identification are not available in MSF settings. And this is very important because the type of CPE identified does condition the type of treatment. So it's very important for the lab to be able to identify the class in question. So we'll look into this very simple lab test, which is called NG-CARBA5. It does detect the 5 most common carbapenemases from a bacterial colony, and you can observe 1 line per type. Now, the performance level, as published, is very good. However, it's never been used on African strains, and we think that maybe the performance could be different depending on the carbapenemases that are tested and the organism tested. It can be compared with a phenotypic method used specifically in MSF labs for this study, and it could be reused in the future. But it can also be compared with the molecular method, which is the gold standard. However, this whole genome sequencing method is very costly. So our objective is to assess the accuracy of the test to detect CPEs and compare it to reference methods. We also looked at the ease of use and ability for lab technicians to interpret the tests. It's also something that could help us to determine the algorithm for screening and confirmation of CPEs. And also, the study will help us to determine the prevalence and genotypic characteristics of these carbapenemases. This is a retrospective study based on bacterial isolates, which were frozen. We've been working with Beirut, also with the American University, AUB. I'm going to show you the preliminary results. In these 3 labs, we selected gram-negative germs isolated between 2019 and 2021 in Kinshasa and 2024, and we confirmed the DST on Entero and Pseudomonas. We also tested with a carba5 test, and the SIM method questionnaire was filled in by each lab technician after their training and after the end of the study. For Acinetobacter, we use only sequencing since the carba5 test hasn't been validated for them. Here are our preliminary results, and so comparing the rapid test and the SIM method shows that it's in good agreement, both for positive and negative tests. Now, some 70% of these bacteria produce carbapenemases that contribute to resistance. Now, if we look at sequencing, the agreement is still good. However, there are 3 false positive with the carba5 test. For typing, we have shown that in Niger, Jordan, we find a majority of NDM. With the final results, we'll have the performance of the test for each type of carbapenemase. Now, let's turn to Pseudomonas, less frequently isolated in our lab, study labs. Now, here, the agreement is 100%, and you can see that the expression is this one, and these sequencing has shown variability, and we've seen NDM and OXA non-48-like. Niger results are not presented because we haven't detected any resistance to carbapenem yet in our study. The ease of use before and after the study, the lab technicians tell us it's easy to use, easy to interpret. However, the preparation of the bacterial inoculum is perceived as quite tricky, and the CIM method was perceived as difficult for interpretation, for implementation. You have to wait for 4 hours to read the results, and therefore it might not be easy to fit in the routine work of the lab. There's good agreement with reference methods. However, for carbapenemase confirmation, we're still waiting for carbapenemase typing, but it seems that for the OXA line, there are some discrepancies. Now, the ease of use, as reported by the lab technician, is compatible with the routine use in MSF labs. We're still expecting the typing of A. baumannii for carbapenemase type description. Now, with all this, we'll be able to come up with a lab diagnostic algorithm to be defined with or without the rapid test. Of course, we need to optimize cost and time, and also pay attention to the country and the type of organism. However, on the basis of our preliminary results, it seems that it's possible to confirm carbapenemase in our labs, and these are important results to guide therapeutical recommendations, prioritize for potential introduction of new antibiotics, and also have the advocacy and the IPC measures we need. However, there are some limitations because there is no clinical data associated with patients, and we need that in order to have more information on these bacteria resistant to carbapenem. Finally, it's very difficult to generalize our results. We can't use this everywhere. We need to fine-tune our recommendations depending on the context. I'd like to thank all the participants to the study and those who contributed to the implementation in the 3 countries, and more particularly for the team in Gaza, because we had planned to implement the study in Gaza as well.
Thank you, Céline, and all our speakers. I open the floor to questions.
Donc j'ai une question
I do have a question
concernant les carbapenemase.
On carbapenemase, on the CARBA5 test.
Qu'en est-il ou que pourrait-il en être pour les carbapenemases qui ne sont pas dans le groupe des 5?
What about these carbapenemases that are not included in this club, as it were, of the 5 carba, either already transmitted by Klebsiella bacteria or emerging carbapenemase? So practically, how would you deal with that in a lab? How would you take that into account? No, thank you very much for this question.
Oui, en fait, c'est une très bonne question.
Yeah, and it's a very good question. Now, we had a twofold objective, assessing the rapid test, but also describing the circulating carbapenemase in the population in the study. And before this study, we had no idea about that. And the limitations of the rapid test is also the fact that there might be some circulating carbapenemases that are not identified by the CARBA5 test. And this is already the case for Acinetobacter, or when there are several different bacteria, because like in a man, you have people coming from different countries where the level of resistance is different and the enzymes in circulation are also different. So this is one of the limitations we are going to look at in our study. Interestingly, this study is really twofold. What is in circulation, and can we use this rapid test to identify those carbapenemases? And if not, what should we do? And how should we treat?
Bonjour. Merci beaucoup.
Hello, thank you very much for these talks, highly interesting. My name is Iris. I'm involved in research on AMR in Brazil, and I'm a medical doctor. How could MSF use whole genome sequencing in the overall monitoring of antibiotics resistance in Africa? When you take a look at the maps, you can see that there's a shortage of data in Africa. And we need to understand better what is the transmission and the epidemiology in the various countries.
Absolument, vous compléterez. Merci pour la question.
Thank you very much for this question. Indeed, this is quite a critical issue, and also the nanopore technology. It has its limitations, i.e. the cost, in particular, so that we could use it routinely for diagnostic purposes and for confirmation. As we speak, MSF has got a project to test this technology, in particular for IPC. So we'd like to evaluate the technology and assess the circulation of strains and comparison between strains, and what about the clinical strains? Are there any epidemics? So how could we use this sequencing tool to track the transmission of bacteria, horizontal transmission of bacteria between patients in hospital settings? Now, we've been exploring this in a retrospective way to better understand how transmission takes place in hospital, but we haven't contemplated its use as a routine diagnostic tool, more as a surveillance tool, and also to explain and see and describe what goes on in our various settings about transmission between patients, but also within the communities we serve.
Oui, je suis absolument d'accord avec vous.
Fully agree with you.
Ce que je voulais dire quand même, c'est que
one more thing I'd like to say
de séquençage
about these sequencing techniques
de la transmission,
for
les travaux sont
tracing transmission.
Qui a fait ça avec ses collaborateurs sur
Peacock has done it for vancomycin-resistant Staphylococcus, and I think they published 2 years ago. However, it's still very much in the field of something exceptional and not part of the epidemiological routine. And secondly, about diagnosis and diagnostic tools in the lab. On the basis of my experience and on the basis of the work we did in Cambodia or Senegal on neonatal infections, I'd say that the biggest issue, even before resistance was taken into account, was the diagnostic of severe bacterial infection in children. We shouldn't lose sight of this problem. It's all very well to have our these projects, but having cultures in remote areas or rural areas isn't really easy. So, and we shouldn't forget that we need also to be able to diagnose these infections.
Hello, it's Christopher from MSF. One question for Dr. Gerald and one for Emily. So for Gerald, just a quick question regarding how you selected or included the asymptomatic females in your sampling. Was it based on reporting of symptoms by their sexual partner, or was it just random selection for people who came to the clinic? Knowing that, of course, usually we would not be testing people who are asymptomatic. And then for Emily, I didn't catch if the results that you had led to any kind of change in the empiric treatment, knowing that for the first 48 to 72 hours prior to having at least gram-negative or positive results, you would need to start treatment anyway after you take your samples. I didn't catch that. Thank you.
Thank you so much for your question. So from our study, we selected anyone who met the criteria. So it was someone between 16 and 19 who was sexually active in the preceding 12 months, whether they have symptoms or not, and they are willing to consent to be part of the study. So the asymptomatic would fit from that criteria, and they were included. Thank you.
Hi. No, so this was a retrospective study, so we didn't actually change any empiric treatment at the time. But as I'm sure you're aware of, with the MSF pediatric guidelines that were updated in 2024 but are pending review, there is the proposed change to the first-line treatment. So we do expect that to be coming through. Rupa, do you have more?
Yeah, I can complement that. So this is an issue that we are facing in several projects where we have access to microbiology, and we're seeing alarming rates of resistance. The question is really, even though we go through this data cleaning process and analysis process to develop these cumulative antibiograms, I think we are lacking a vital piece of information, which is more clinical information, because I think in these patients we are seeing a biased population. These are patients that have likely been pre-treated with antibiotics either prior to hospitalization or within the hospital, and so I think it is very difficult to pull the trigger and say, based on these results, we should be switching now. That said, I don't want MSF to be unilaterally making these decisions, and so this is part of a larger discussion with other humanitarian actors, including the WHO, to say we need to come up with some guidance about how to use this data so that there is some consistency from country to country, rather than each hospital, each context make up their own rules. But because what's at stake here is, should we be switching to meropenem? And because that is what evidence would suggest is the safest, most efficacious antibiotic for ESBL bloodstream infections. And are we ready to open that door? I mean, I think that's a long way of saying no, the recommendations have not been implemented into guidelines, because I think there is real uncertainty about, is this the right thing to do? And if it's not the right thing to do, then what is the right thing to do? And I think we need more clinical information to be able to make more informed decisions, and we need to collect that prospectively. And I think we probably should be thinking about doing a clinical trial to assess different clinical regimens, but that's a bigger discussion for another day.
Ok, moi j'ai une question. Merci beaucoup à tous.
Now, thank you very much to all of you for your very nice talks. About the last presentation,
les systèmes de surveillance.
Now, the AMR surveillance system you've just introduced, how does this system interact with the health system in each country? Because there are already some surveillance, there is already some surveillance with the WHO platform in the majority of countries. How do you work with these surveillance systems? And also, how do they work with you, with the MSF projects? Are these patients, MSF patients, then seen in those hospitals, and then they are sampled? How concretely do you organize things?
Alors pour notre étude, on a utilisé des isolats bactériens.
We used bacterial isolates from patients hospitalized in our MSF hospitals. So we sampled patients in our MSF hospitals. The MSF lab analyzed the sample. We gave the antibiogram to the clinicians. Then we stored the bacteria, and this is what we retrieved from these labs to test carbapenemase. Now, the antibiogram that was performed on the day the culture became positive, well, this is what you call a routine result. It's a microbiology result for a given patient. Well, and then, according to the country, the MSF programs and projects may be different from one country to the next, and the surveillance system may be different as well. Maybe someone from MSF could tell you more about this, but I know that the antibiogram are forwarded to the GLASS network in Mali, for instance, and some results of antibiograms are then forwarded via the central network and are fed to GLASS, and likewise in other countries, but it's not the case everywhere. So we forward, of course, these results to the MOH in the countries where we worked, where we carried out the study, because we want to give them access to this data. However, the routine results are also supplied by MSF and by other networks.
Juste un commentaire.
I'd like to make a very short comment.
Est à mon avis une question qui n'est pas exclusive aux pays d'Afrique.
Doesn't apply only to African countries. The large surveillance networks find it very difficult to get access to good clean, robust data. And even in France, not all districts or regions participate in the AMR network or surveillance network. And it's a real problem. As soon as you want to have something a bit sophisticated about the distribution and diffusion of this resistance, well, you're faced with a lack of quality data. And we've been working quite a lot on this point. I'd like to ask a short question to ACI.
The question was, how would you consider salpingitis without vaginal discharge? I mean, without any result in bacterial identification. Yes.
Okay, thank you. So we were looking at the common 3 causes of STIs, the chlamydia, the Neisseria, and the trichomonas, and usually they are associated with that discharge. So for those without the discharge, if they were presenting with any other symptoms not STI related, they were not getting treatment at initial consultation. But if their test result came back positive, on the follow-up we would give them a call, and then they would come back to access treatment. So at initial consultation, they didn't get any treatment.
Any other questions? But just with the comment on glass and surveillance, you can't use surveillance data to create guidelines for treatment because it's all comers data. It's not stratified in any way. Thank you all for a very interesting session.